Welcome everybody to Harbourview Medical Centre. My name is Dr Souter. I am the Chief of Anaesthesia here since 2010. I'm here to welcome you to our service, which is really one of the key areas of anaesthesia provision within the University of Washington system. This is the major trauma centre for the Pacific Northwest. We specialise in neurosurgery, burns, plastics, and a lot of orthopedic trauma, a lot of spine trauma. So you can expect your time here to be busy, you can expect it to be educational, and you can expect it to be interesting and fun along the way as well. Here are a few things that will help you have a great experience here at Harbourview Medical Centre. If you find yourself that it's the end of the day and you've finished the cases in that room, or it's the beginning of the day and you find that you actually haven't been assigned to any patient care duties, your approach is the same. We want you to report to the anesthesiologist in charge, or AIC. There's 7 of us who regularly feature as the anesthesiologist in charge. You'll be able to look up at the whiteboard, the electronic messaging system, and be able to see there on any one day who is the anesthesiologist in charge. But report to them, let them know that you are free of assignments, and they'll find something for you to do. Our surgical schedule for the next day comes out the preceding afternoon between the hours of about 3 to 5 p.m. On that schedule, you'll be able to find out who the attending is that you're working with, and the patients and the types of surgery that will be expected to anesthetize the next day. We want you, in the case of inpatients, to go and see the patient. Go and determine their needs, make an assessment of them, and then be prepared to call the attending and discuss a plan of care. In the case of patients who haven't come into the hospital yet, they're either coming in as outpatients or they're being admitted on the day of surgery, we want you to go and look up their medical records, especially concentrating on their visit to the pre-anesthesia clinic, and make an assessment of what is known about them at that time. But again, we want you to call and discuss your findings with the attending that you're working with the next day. The attending is expecting that call. And to that end, we've listed a sheet that's got 3 numbers on it for every attending. Those numbers will be their pager number, their cell phone number, or in some cases even their home number. And what we want you to do is to call those numbers in the order given, which is usually at the individual preference of each attending, but to make a really good faith attempt to try and get hold of them, as they may be busy in the middle of patient care in an operating room somewhere, or maybe busy at a late meeting, etc. But we want you to make a good faith effort to talk to that attending. That discussion will allow you to throw around the ideas that you have for the plan of care, make any adjustments as necessary, and also allow the attending to perhaps make some suggestions about changes that you might make, but also to suggest perhaps some reading that you might undertake for a fruitful and profitable discussion the next day. Given the types of patients that we see here at Harbourview, it's highly likely that at some stage during a rotation you will actually have to transfuse blood into a patient. We have very specific protocols to follow in this circumstance. Protocols which are not just local to this area, but in fact have to incorporate national standards. So it's really important that you follow those standards. The protocol will actually ask you to double check everything. You double check the patient's identity against their armband and against the anesthesia electronic medical record if the patient's armband is not accessible. You must check the individual details of that unit of blood, the blood type, the date that it's being issued, the date that that cross-match will expire. All of those things will be checked from that unit against the pre-printed sheet attached to each unit of blood. And it's really important that when you are getting blood out, don't leave it lying around. These units of blood are an expensive and valuable resource that have been volunteered by members of the community. If you leave that blood out for too long, it ends up having to be discarded. In other words, you've put somebody's donation to absolutely no use whatsoever. So when you take a unit of blood out of the fridge to check it, make sure it goes back. Don't take a unit out of the fridge thereafter unless you intend to transfuse it. Only call for 1 unit at a time if you possibly can, but be very mindful of the fact that this is a scarce and valuable resource. Given the amount of seriously ill patients here at Harborview, it's highly likely that you will be transporting patients between the operating room and the ICU. This is especially important at the end of the case to plan everything correctly. What we want you to do there is to telephone the receiving unit about 30 minutes before you're due to leave the OR. That's to provide what we call a safe landing for that patient. In other words, to make sure that the drips they need running, that the ventilator that needs to be there, all those things are set up and ready to await your arrival. You don't want to turn up and have those things not be there. Transporting the patient is a detailed exercise with lots of moving parts, and we'll actually talk about that later. Our educational mission here at the University of Washington, and indeed at Harborview, is to make you the best anesthesiologist you could ever hope to be. To do that means that we have to educate you in all aspects of the task, both in terms of the learning that you will need to do when going to textbooks, but also really how to behave in the OR and how to perform in the OR. The details of how to turn a room over, how to prepare a room, how to set up particular cases, those are all crucially important and will really influence how other people perceive just how slick and how prepared you are. Those are really important skills to get, especially in your first year of practice. And so it may be that we want to concentrate on those elements of care, in other words, the practical day-to-day realities of doing the job, to get you practiced at that, before concentrating on some of the more abstruse theoretical aspects of anesthesia care that are best perhaps handled in later years of training. But we really want to make sure that you are as well prepared and as well versed in the art of anesthesia as the science.